So, welcome to pediatric nursing. Most of you are almost in the end of your course. Some of them are, I know, do have pediatrics with maternity, but many of you are those students who are just with your pediatrics with community, also with a med surg too. Now, I just put everybody on mute. During class, put you on mute. If you need to talk to me, unmute, talk to me. At any time where you have a question, I'm not understandable, or you have another thing you want to figure out, please don't be afraid to stop me. I am never insulted by that. And I appreciate when you stop me because I'm sure somebody else has that same question. So I've been at Fortis for a long time, since 2017. I started in Cutler Bay. I taught pediatrics and I taught pharmacology. They asked me when I went in to sign up full time. So I know you could do pediatrics because I've worked at Nicholas Children since 1994. So I guess it's 30 years ago that I started there. And I only stopped in 2017. So a little bit of pediatric experience. And then they said, do you think you could teach pharmacology? And you know what I said? I said, I think I'll fake it. But I learned again how to do pharmacology and to understand it and to be able to teach it. And of course, dosage calculations are a bane in many of your existence. If you all do not know dosage calc, I'm going to be sending you some recordings I've done. I make it simple. This ratio proportion, I do not do that. It doesn't make sense to me. But if that's what you know, the way I teach shows you how to pick out those numbers that you need to use. And anybody who needs a one-to-one in 15 minutes, I'll get you understanding mics per kilo per minute. Okay. That's how easy I make it understandable. Nobody should get 2 points off for any math question. Okay. So that's to you. You come get to me. I will teach you how to do it. And you won't be the first student that has nothing to do with math, don't understand it. They don't, know how to do it. And I get them getting every question correct by the time I'm done with them. So please come to me with that. So I went online when they went pediatrics online, and it was right with COVID. I've not been back to campus since COVID. And then they opened up pediatric specialty all online. In fact, that's why I went back to do a PhD so that I could teach online, because I know that I do have rheumatoid arthritis. I do have some bad days where I don't move very well. So for me, I knew I had to do online, and I knew that I still wanted to teach because I just love teaching, and I love seeing the bells and the whistles go off when you start to understand and put those dots together, because that's what nursing is. And nursing is only common sense. There's nothing more than that. So that's a little bit about me. I've got a husband. I've got, oh, how many grandchildren now? 3, 6, 7, seven of them now. And you're going to hear about Christian all the time. He's the one who lives next to me, and he's turning 7 tomorrow. So you're going to hear little stories about him and what I've done and my other grandchildren. And I'm going to be telling you stories about children from work. And, every kid who was my patient, my client, at a hospital are all my kids, because once I'm their nurse, they become my kids and I give them my all. So I'm going to tell you lots of stories, and I think that's going to help you understand. So my style of teaching, what do I do? Well, I do have PowerPoints, and I do go over them, and I do send them out early to you. And then when I'm done with the PowerPoint, I do have a Kahoots. Now, these Kahoots are those concepts from the PowerPoint that I'm reinforcing. So number one, you get that, me talking about it, and immediately you're tested on the information. And if you're smart enough to say, oh, I didn't understand this concept, and then go back to the book and read about it more, or listen to the recording again, you're going to be able to understand pediatric nursing. We're going to do, of course, reviews. All of the professors do reviews. I am the lead pediatric professor, so I will ensure that you have all the reviews from all of the professors, and I will be sending out times. And remember, all my times are Eastern Standard Time when I put them there, and I will write them there in case you're in another time zone. Okay? So this class, we are a little bit longer. And why did we do that? Well, Martin Luther King is next Monday. You do not have class. So in order for you to get the proper time you need by accrediting bodies, we increased your class time a little bit. Now, you have a decision to make. I can teach all the way through and get you out early, or we could take a break between the PowerPoint and the Kahoots. What would you all want to do? Now, I don't mind if you have to go to the bathroom. I don't mind if you need something to drink or a snack to eat. That doesn't bother me, as long as you're on camera and you're paying attention. What would you like to do? Go through or and get out early, or would you like me to give you a break?
I'd rather go straight through.
Okay, that's one.
I'd rather go straight through.
Anybody need a break? Okay, there we
Go
go.
straight through.
All right, I'll go straight through. And again, if you need to get up and you need to go somewhere, go to the bathroom, take care of your business, answer the door, your kids are coming home, the mailman comes. I understand those things. Just send me a little message in the chat box so I know what's going on. And that's all I request, a lot of good information. So today we got a lot of things we're doing. Number one, we're going to go over that PowerPoint about online learning from Dean Brown. The second thing we're going to do is the PowerPoint for the week, and then we're going to do a Kahoot. So much stuff. So let's get her done, and let's start out with our first thing.
I have one question.
Absolutely.
So we don't have school Martin Luther King Day. What day will we take that quiz?
We're going to be taking that quiz on the beginning of the following week. You're going to do a double quiz.
Okay, I was gonna say because I see a quiz already on there. So
There
we
is
take two
good
quizzes
question.
on that Monday.
The following Monday.
Right.
Right. So
Okay.
you're going to be tested on this week and next week. And the quizzes are from the week before's information. So it's not on the week that we're going to do. All right. So week one, this stuff will be on your quiz next week. And then quiz two will be on what week two was. I don't do the same week, the same lecture as a quiz. And they are at the beginning of class. So make sure you're on time.
Right. Week 2, there is no class. So the quiz for that, when do we take that lecture?
Week three. Week three.
3.
We'll do 2 of them.
In the
Is that
beginning of
okay?
class?
Excuse me?
We'll do 2 of them in the beginning of class?
In the beginning of class.
Okay.
I mean, unless you want one in the beginning, one in the end. But I think that would confuse me.
I'm just grasping if we don't have class on the second week, what material will we be tested on the beginning of the third week if we didn't learn nothing from week 2 or didn't have class for week 2?
Well, you're going to be getting a recording.
Okay.
You also can come to another class if you want, but a recording is just as good. And I'll be sending you, I think probably last semester's recording initially to get you something right away. Maybe it's that Sunday, before week 2 that you can look at something, you'll have it. And then when I do another recording that week, which will be Wednesday night at 8:00 at night Eastern, I'll post that one to you. So you'll have this semester last, but they're about the same. There's not much difference in them.
The Wednesday at 8:00 is also your class?
Yes.
Okay.
So I have 2 RN classes. This class at 2:30 on Mondays Eastern, and then Wednesday, 8 p.m. Eastern is my other class. Okay?
Okay.
All right. Let's go ahead and let's go over this PowerPoint. And these are the rules, the guidelines, things that you need to know about online courses. So the one thing, remember, just because we're online, it is still a class. Okay? You need to come to class on time and be prepared. I mean, I don't care if you come in your uniform or not. Just be appropriate, okay? The one thing, don't be in bed. I don't like looking at somebody relaxing in bed. I like to be relaxing in bed. Be sitting up, be aware of what's going on, okay? As I said, I don't mind if you have something to eat or drink. I know 2:30 in the afternoon, you may be just getting from somewhere else, and that's the only time you have. I understand that. That does not bother me. I will go over what's new every week, and I'll do that when I get to the PowerPoint, and we'll go over this week's learning and some little clues about that. So whenever you have a problem, the one thing I want you to know is communicate with me. I can't come to class because my dog got hit and I'm at the vet. And this is before class, and there's a quiz that day. I'll let you take the quiz. Just send me information from the vet that showed that. Or you had to go with your daughter to the doctor's because she had asthma attack. Send me information that proves it. I'll let you take the quiz. But don't contact me. Don't tell me anything until after class. You will not take the quiz again, okay? I will work with you, but always, always communicate before things happen. Now, I do have a cell phone. It is listed in the welcome. I tell you that you can contact me on Canvas, email. I answer them pretty quick. You know, like everybody else, I have it on my phone. I'm looking at it all the time. You'll see on my welcome message that I'm available from like 10 in the morning till 8 at night. I'll check it up to the point I go to sleep to let you know information. I've been told I'm pretty quick with the answering. Now, what if it's something like right now, like I'm really an emergent? You can text me. So anybody who didn't have my cell phone before, write it down, program it into your phones. It is 305 951 8055. And I request when you are texting or calling me, it is something that cannot wait. It's emergent. I can't be having texts from 100 students, you know, with, well, what does that assignment mean? And, you know, that's something that I can answer, you know, in a message, okay? So just be, you know, conscientious of that, that there's more than one student that I'm working with, all right? But I will communicate, and I am pretty quick. I'll always put feedback on your discussion questions all the time. You can see you got a 20, 20 out of 20. Go back at the end of the week after I grade them. And I put some really key information in there. Sometimes it's the only place it's covered in the course, but at least it's there. So go back and read those little messages. So we know there is that the course gets started about your structure, everything's there. I tell you about me, I tell you about my grandkids. I like to swim. I mean, it's my favorite thing to do. And I love to teach. And I've been teaching even as a regular nurse my whole life. I've been always that approachable person. Now, I am the course lead, so any concerns come to me. I don't mind if you can't get a hold of me and you are having a problem to go to Darlene Brown, Dr. Brown. It does not bother me. She is your second line of defense here. And I'm telling you, I don't think the woman ever sleeps. She's always available. And she is on Pacific time. She is in Phoenix. And she'll be answering things from 4 or 5 in the morning till I don't know what time at night. So always available. There's her phone, there's her email. Use that if you can't get a hold of me. And it's something that you need to talk to me about, okay? So whenever you communicate, don't put big capital letters, be courteous, be like you were going to be talking to a physician or a supervisor at work, okay? As in be respectful with it. I am here to help you, to guide you. I will always be open to questions, anything you want, okay? Now, our classes, I've already mentioned that we are from 2:30 to 5:15. Because it is a class that's almost 3 hours, we get about 25 minutes of break time, which means we should be done about 10 till 5 at night if we go straight through, okay? There's probably 1 week, it might go a little late, and it's week 5 because it's cardiac respiratory. And it's a heavy week of understanding and concepts, okay? But usually I can get it right in there. Now, discussion boards. Yes, there is a discussion board question this week. You should have the first one in by Wednesday, and then you should have the peer responses in by Sunday. Now, many professors like you to do the initial post and wait for, the peer responses. I don't care if you do them all at once, all right? As long as you are looking at other viewpoints of that question. You see what I'm saying? Because what you think is not as different, be something different somebody else would think. I mean, I remember reading a book for my PhD about the taste of chocolate. And chocolate, what I taste is different what you taste, and the description can be different. So, and I didn't know why we read that book, but I sort of understand it now. It's that reading different viewpoints can give you better enlightenment and understanding, okay? I usually will on Thursday send you a message. Hey, don't forget your discussion question. All right. I'm pretty good about sending you out reminders. Professional code of conduct. Now, I did just send out another announcement from the dean. There has been some issues with some websites that students are copying from. I warn you, do not do that. They are not approved. They are not scholarly websites. They're basically information that they have posted that I know these websites and I can see what you've written and I know they're plagiarized. You'll get a 0. Okay? If you do it again, you could be dismissed from the program. So please, please, please don't go to these websites. Do not use them. Use your own words, okay? Very, very important. And that's part of that plagiarism, all right? Now, week 8, there is a pediatric assessment project. Sometimes the plagiarism checker comes back pretty high. I will give you a chance to correct it, as long as it isn't from one of those sites, okay? Maybe you didn't know how to quote. Maybe you didn't know how to say it. Maybe you didn't cite it within the body of the paragraph. I'll work with you. It's not like I'm going to hit you, poof, you're plagiarized. No, I'll work with you. I'll send you messages. As long as you do what I'm saying, if you don't understand, let me know. What do you mean? We can meet a quick Zoom whenever you're available, and I'll work with you, okay? Let me see. Also, remember the academic integrity, making sure that quizzes and exams that we do it and it's your own work. Okay. We know that there's a bunch of stuff that goes on, behind the scenes in the Zoom land, but please remember, if you cheat or you do things that are not ethical, it's going to hit you in the end and you're not going to pass your NCLEX. Okay. So try to do your work as much as you can. And I want to tell you a little hint about me. When I graduated from nursing school, I worked my butt off, but I'm not a test taker. I had a 2.28 GPA, and I'm one of the best nurses you'll ever meet because what my 2.28 is, I earned every little point of those things. And C equals RN. A doesn't mean you're an RN. It just means that I did all the work myself. So please do the work yourself. Don't copy it and make sure that you put in your best efforts. I give you every tool you need. You've got PowerPoints, you have Kahoots, you have study guides, and I give reviews that are spot on. If you understand it, you will do well in this class, but you have to put the effort in, okay? So again, this is all about code of ethics, making sure that you are doing what you're supposed to do, okay? Nurses, nurses are, when I started nursing, if I told you my salary, it was a little bit above minimum wage. I worked night shift. the minimum wage was $2.10. You know what I made on the night shift as a brand new RN? $4.10. So we've come a long way, haven't we? And it's that professionalism that keeps us growing and becoming more of a profession that's looked at, and now we're being paid for the what we do and what we put in and our integrity, okay? Again, those sites that cheating, I can't go anymore. Here's the names of some of them: Studaco, Course Heroes, Stuvia, and they go on and on and on and on and on. Please do not go to them. We can see you're there. The dean looks at those sites all the time, and there's other people within the corporation that are also looking. So don't go in, don't sign up. It will come back to hit you, okay? And I don't want anybody, because they're looking just to see what it is, to have any repercussions. Just to let you know, okay? You've been forewarned. Don't do it. Work should be turned in by Sunday, 11:59 Pacific time. If you're Eastern time, that means 2:59 a.m. Okay? If you turn it in on time, you get the full grade. If you are late, you have till the following Sunday to get it in with a minus 10% deduction. But if you notify me before, I was going to be doing that today, but I had to go to the ER, here's the information that proves it. I'll let you get that another week with no deduction. Again, did you hear? Before it's due, let me know. Once 2 weeks are up, it's done. There is no redoing it. You can't go back and do week 3 and NCLEX questions on week 8. It won't happen. It cannot be done. Attendance. Now, as I said earlier, not all of you heard it. The first week, I'm a little easier on coming into class. Now, on the Zoom log, I can see when you come in and when you leave. 1 minute after 2:30, 2:31 is 15 minutes late. Everything is 15-minute increments, okay? And if you leave early, it again, 15-minute increments. And I think you all understand by now, if you've done maternity, 20% if you are out. And this could be one day that you didn't come to class, and then here and there, late, leaving early, could decrease your grade letter by 1 grade. If you're going to get an A, you get a B. You get a B, you're going to get a C, and you could fail the course just from attendance. Another thing is attendance is also not only the time spent here, it's logging into your Canvas shell, which means putting something in there. This week, you have your technology quiz, sign up this and that, right? And you have a discussion question. There's 2 points of entry you need every week, okay? If you do not get to class for whatever reason, there is no makeup. But for instance, I know somebody had said, well, I'm having a procedure the day of class. Send me the information. It'll be excused and it will be looked at because you told me before class, right? Number 1. And number 2, you have documentation, what happened. And Dr. Brown looks at that and will not make you that 20%, even though it could look like it on paper, okay? So make sure, number 1, you post in Canvas. And if you are not going to be in class for whatever reason, documentation, okay? Again, I went over that 20% deduction. Now, when you start seeing these little letters coming from Dean Brown and her assistant, Debbie Northrop, will be sending these 5%, 10%, 15% of attendance missed. Be aware of them. Now, if you've sent me documentation for attendance missed, you were at the doctor's, your dog got sick, your child, your grandmother, whatever, I got that information, make sure you send it to me and Dr. Brown. I also will send it, but just to be sure, always cover all the bases, right? We don't want anybody to get 1 letter grade. last semester I had one student it happened to, and she ended up failing the course. And I don't want that to happen to anybody, okay? Because I think I'm very clear about that. So every week, I don't know the way that you do it, whether you have a piece of paper, you have it in your phones or on the computer, make sure you know what's due. I know some students print the syllabus and have color code markers when they do things. These are due, and then they color code them or they X them out. Whatever it is, keep yourself organized. If you are that student who is in those 3 courses, you're going to need it, because about week 7, you're going to go a little crazy trying to keep up with it. So make sure you have some method of keeping yourself organized. Very, very, very important, okay? When you are doing any, like the project, if you're not understanding what the rubric says, please ask me, send me messages. I'll be going over it a little bit more, especially those weeks that are a little light on homework. I'm going to say this would be a great week that you start doing your project. I'm going to try to help you, because by week 8, you're going to have med-surg is going to be, oh my goodness, I got to study it. And you have your community, you have another project due, and you don't know how to keep up with it. I'm going to try to help. Just listen to what I say. I'll guide you. I'll get you through this, and it won't be as difficult if you listen. Again, you always log in. I don't write a lot of announcements. I'll tell you now. I only write important stuff. I'm not the person 6 announcements a week. No. You'll number 1 see information week 1, and it will be what is due, what we're covering, and any handouts I want to give you. After class, almost immediately, about within the hour, you're going to get week 1 recordings. And I will post the Kahoots, and I will post the PowerPoint and any handouts that might have happened. Okay, so you should get it twice: your handouts, your PowerPoints, and you'll get again that recording. And I do that tonight before I turn off the computer today, so you get information pretty quick. Internet seems to always be a problem. Some students live in areas the internet's not that great. Just try to make sure, if this is one of you, especially during quiz and exams, make sure you're in a place that's quiet and that your internet is stable, that you can get through. Now, what happens if you're taking a quiz and your computer just shuts off? What should you do first? Let me know. Send me a message, right? And I know by looking at the timestamp, and I could go back and look at every question that you've pushed on quizzes and exams. And when you send me that message, I can say, yes, this is when it happened, and I can let you retake a quiz. Or let's say it was an exam. Don't worry, exams don't go away. They don't disappear. I can reopen them, and I can get you started where you left off. Again, communication is key. Have I really emphasized that really good enough? As things happen, let me know with things like that, or before, if you possibly can. So day 1, did anybody have any problems going through online course, looking at information, what you need to do? Did anybody have a problem downloading the textbook? Okay. I had some students send me messages, they couldn't get the textbook down, because I was going to say, all right, somebody show me how to do it, to guide other students through it. Again, these textbooks actually are really good, and they're not like overly wordy. What's great about them, they even have little quizzes on every chapter. I would go through and do those quizzes because it does help you with concepts. A lot of you students don't realize they're there, but this textbook has it. So make sure you do go through them. Look at week 26. What are some questions there? And they can help you, all right? Again, Another way of re-emphasizing. If you come to class prepared, listen to the PowerPoint, you do those Kahoots, you've already 3 times looked at the information, and then you're going to study them again. That's 4 times. It should be a review by then, okay? I know that with teaching and students, it's the repetition that helps you remember things, okay? So try to come to class prepared. If you see, I don't put any review sessions out weekly. What I say to you, if you are in a week, you're confused, I don't get it, I don't understand, come to me and I can set up a time with you and I'll work with you on your time. And we could go over, maybe it has to do with a cardiac, maybe it has to do with tetralogy of Fallot, or respiratory has to do with cystic fibrosis. You don't get it, I can explain it, and you'll understand as I start to teach. I teach very simplistically. So I'll tutor you when you need. So please come to class, try to come back to class prepared, and remember, every time you come, whether it's to me one-on-one or into an exam review or class, I do take attendance. And I want you to know that those students who maybe are 77.8 at the end, and Dr. Brown looks at, they've come to reviews, they've gone to all the exam reviews, they've done extra reviews with the students, with the professors. She looks at those things, and there might be things we could do to help get you to that passing. But you have to show the effort. It's nothing that you can do at the end. There's no extra points. But when you show that enthusiasm and that willingness to learn and reaching out for help, that's what Dr. Brown wants to see. As again, tutoring helps. It really does. I've had some students come in every week. We go over key concepts. We go over the Kahoots and say, all right, what didn't you understand? Or I say, tell me, you've gone over this stuff. What has you mind boggled? And I'll help. Now, the KGAs, this is in your syllabus. This is just a generic one. This is actually mental health, but it's really similar. Unit exams, there's 3 of them. It's 55% of your grade. Quizzes, 1% for each quiz. And then, of course, your HESI is 20%. You do have CJ Sims. It is worth 6%. Your NCLEX is 5%. And then you have a pediatric assessment project. And that is 6% of your grade. And that's why I let you turn it in, get feedback, and return it back in for you to get your best grade. That's why I say start early, and I can help you get that perfect grade, but start early with me, okay? And then in the end, always before your NCLEX, your HESI, you're going to see that pediatric practice or assignment exam, and they're in all the courses there, okay? And you do have sim and you do have clinicals here. Now, initially, we have all of the homework grades turned off. So all you're going to see is exams and quizzes, those grades. On week 6, I'm going to turn on the homework grades, and I'm going to show you how they can impact your grades, whether good or bad. If you haven't turned stuff in, your grades are going to come down. The homework grades or subjective grades, whatever you want to call them, are worth 20% of your grade. And you will fail unless you have 100% in your quizzes and your exams. It's 20%. That means you start off with an 80 if you don't do anything. So please, please, please do your homework. Get it in. And I send you messages. Hey, you didn't do your NCLEX. Get it in by Sunday with a minus 10%. Or sometimes Sunday night, evening, I'll say, hey, you didn't get this in yet, get it turned in. Especially those students, which I know really need those grades to be a 78 or higher. And I always suggest, please, when you turn stuff in, at least turn it in on a passing grade. Even NCLEX, at least a 78. You don't want it to pull you down at all. I mean, you want it to pull you up, but you don't want to pull it down, okay? And then on week 8, we turn those homework grades back off, and then we're not going to turn them on until after the HESI remediation and that is your final grade, okay? I can't turn just one student on or off. I mean, you all know how to take and put and poke in your little numbers and know what grade you need. I know you all know how to do that, but I can't do a single person. So, and your KGA has to be 78.0. And then when it is there, we will add in the homework grades. When that is added in and you're still 78, you have passed this course, okay? So you need 2 devices for your exam and quiz. So come in on your exams, so you can run your exam there, and then your phone on Zoom. Now, the one thing students forget, have them plugged in. I can't tell you how many times I got to go get my plug. You know, oh, it's the battery's almost running out, or the battery runs out and there's no plug. Again, no excuse, because I'm telling you now, make sure you have charging capability, okay? Quizzes, there is only one attempt. It does go forward. It can't go backwards in questions. Again, it's at the beginning of the class. And let's say your camera turns off. I can't get a hold of you and it's black. Your quiz will be a 0. So be very, very aware of it. As you saw earlier today, trying to get hold of this student, hey, you're black, like get it on. I went every way. I'll even text you on your phones if I have to get a hold of you. Next week, I will be getting a listing of all your names and your phone numbers, whatever you've given Fortis. So if there's a different phone number, please let me know that. And please be aware of these things. They're very, very strict on it. And I'm telling you, these accrediting bodies do come in. They look at recordings, look at quizzes, look at exams, making sure that we're getting the highest integrity of these exams and quizzes that we possibly can, okay? One of the things about exams, if you have any accommodations, I need to know and I need to have the letter of accommodation. Send it to me next week, or week 3 at the latest, actually. And I will make sure that Dr. Brown has it too, if you don't send it to both of us. Also, if you're going to come in class time to do the exam, I cannot give you extra time. I'm going to go on with class the normal time. So sometimes I have students come in earlier. That's what they want. But again, students are going to come in and prepping. I'm going to be checking their environments. You're going to be hearing that. I will set up other times, other days, earlier in the day, later in the day, in order to accommodate what your accommodations are. Quizzes, I'm okay with. I can do quizzes on that time because I basically will give like 10 minutes after for, you know, to get revamped and up and ready for the class, okay? Now, exam soft, again, you come in on your phones, I check everything out. Again, the one thing about exam soft students get concerned about is uploading. If you can't upload right away, don't worry. Those uploads, they don't disappear. I've gone back 2 weeks later and got the exams. Just if you can't upload, I'll let you know, try again. Sometimes it's literally restarting your computer and then it uploads. Again, you're not going to lose your exam once you've done it. It's always been, if you're like, oh my God, it didn't upload. Oh my God, there goes the exam. I got to do it again. No, you don't. It's going to be there. Exams are 1 attempt. As I said, any technical problems, stop. Notify me right away, and then we can reschedule. All right? Again, accommodations, like I say, please let me know. It is very important because sometimes we take professors and we'll get together, we'll do a group of, you know, different students from different classes together. So just let me know. We'll work with you and we'll make accommodations like I've already said. So when you come for exams, I want your ID. It can be a license or your ID for Fortis. We're going to be checking your environment, ears. I'm going to look at wrists, making sure that, you know, we're trying to be as good as possible in making sure that the environment is clear of anything that can help you as a little helper. Missed exams. Well, again, if you need to miss an exam, tell me before. What happens if the day of the exam you have a migraine headache and you can't even open your eyes? Tell me right away. All right? As long as it isn't every exam, we will reschedule you. I can reschedule you on one of my other classes, or I can put you in another professor's class. Or I could do it me and you. There's many things I can do to accommodate you if we can't get your exam done then. If something is pre-known that you're going to miss, we can again schedule it differently. At another time. I will work with you. You must take the exam within 1 week of a missed class, which means you would need, if the exam was today, you would have had to have done that exam before class today, any day before then, okay? But once class hits, then the exam is a 0. I think again, you see, tell me before, don't tell me after. I mean, I can't, I've said it 28 times already. So quizzes, you go through your modules, put your quiz 1, and it's 15 minutes, it's 10 questions. Again, any problems, just let me know. Just stop. I can always go back and re-update it for you. So don't worry about that. And then your HESI. Now, I have a couple really good HESI things I do for reviews. I've got a HESI Q&A that I've done. Actually, I do the RNs and the PNs together, and it really makes you think. And I have students tell me they can hear me talking during the HESI, and it helps them through it. And I've seen my HESI grades go up quite a bit. Most HESI grades, if you do what I tell you to do, are always above 900. So that means only 1 hour of your remediation time. And that means a lot in the end, okay? So 20% of your grade is your HESI. This is exactly the remediation, what you do. I mean, my goal is everybody to get 1 hour. That's what I want. I don't want anybody not to do well. And I tell you how to get there, okay? Again, always we have IDs, cameras always on, et cetera, et cetera. Most of your HESIs are on campus. And that is any questions about when, that is from your campus dean, okay? Again, here it is again, right? Contact your instructor if you have any problems or if you would like some additional help. Always, always, I'm here and I'm ready for you. All your homeworks, plan your time, get it in on time. I'm going to send you messages. This late work's already there. NCLEX questions. I do open when you can start them. They are open. Now, the one thing I tell you about NCLEX questions, make sure you do what the module tells you to do. The first week NCLEX question is growth and development. It is not under pediatrics. It's under the topic growth and development, okay? If it is not, I will give you a 0, say please resubmit. I'm not going to take points off. You're not going to get a 0 as long as you get it in by that next Sunday, okay? That's always the one that students forget. And I do look to make sure you're doing where it should be. I don't want to see that little green box printed up there. I wanted them submitted. Is what you do is you take that green box, go to that bottom right where it says print results. And instead of going to a printer, you go down and it'll make it to a PDF and you save it. And that's what you upload to me. If you need instructions, I will send you instructions. I have some that are listed out. If you don't send them the right way, again, I'll give you a 0. I'll attach the instructions, get them in by that following Sunday. Remember, once you submit, they're in. You can't redo them, but you can do them as many times as you want. Again, I highly, highly recommend not to hand in anything that's below a 78, okay? And that's basically what all that stuff says. So the assignment and practice exams are at the end. Week 9 or 8 and 10, or 11. And it really, it's quite a few questions, but it really will help you, okay? So make sure that you go and you do them. Make sure all of the stuff you do on your these modules, make sure that you don't try to go through this website. Make sure you go through the modules, okay? Now, the NCLEX, not the NCLEX, but the case study type things, which is your assignment exam, practice exam, they should go directly into your grade book. If it doesn't go directly over, or you see a 0 and you did it, let me know. I have little tricks. I can go look at it and I can find your grades, okay? So just let me know if it's not seen there. CJ Sims, I need 4 things on it. Okay, there's a way to click it where you see your name on the top right. On the top left, it's going to be the sim and the name of the sim, and it's going to be the date, and it's going to be the score. I need all those 4 things. Again, if I don't get it correct, you'll get a 0. I'll send you a message and tell you what you need to do, okay? These paper assignments, which is this pediatric assessment assignment. It is 3 different sections. One's a small paper, 250 words. Start thinking about a pediatric diagnosis that interests you, whether you had, your kids had, your neighbor had, or when you're going to clinicals, one that really interests you, something that makes a difference that you want to know more about. The little paper, tell me about it. Then I'm going to give you, and it's in there in your modules, it is an assessment form. One of the most important things are the theorists and nursing diagnoses. And remember, nursing diagnosis is your diagnosis as evidenced by, related to, must have 3 sections to it. If it doesn't, you'll have a decreased score. I'll tell you what to do. Send it back as long as it's before the due date, and you can redo those diagnoses for me. And then the third thing is teach me, whether it is just a brochure, whether it's a picture board or a PowerPoint. PowerPoint, 5, 6 slides, nothing crazy. I don't need 28 slides. I just teach me. It could be about ADHD and how you would keep your child on a schedule, maybe the medications, side effects, what to look for, whatever. I want to know something about it. Teach a nurse, teach a child, or teach a parent, okay? And follow the rubric, and I do follow that. And make sure that you do have APA on these. Now, this is a project, so give me 3 references on that project, okay? I want to know where it came from. On your discussion questions, 1 or 2, they're no more than that. Just give me a reference. And remember, you always have your book as a reference. You know, one of the things in the way that we look at stuff is, how does this relate to nursing? If you don't get things in on time, we're thinking, well, you didn't give your medications on time, right? So we think about, you know, we need to teach you from now how to get stuff in on time, you know, and how to keep yourself organized. Nursing can be really rough, and your patients today are sicker than ever, and you have to keep organized. I know I could have 2 patients and I'm running like this all night long. My career was, my favorite of all is the cardiac intensive care unit, Nicholas Children's. I actually opened it with the surgeon there, and you could have a patient crashing and burning going on CPS, which is the lung machine, right, in the middle of the night. And you could have them doing mini surgeries right there and everything, and you've got 2, 3 patients. How do you keep organized, right? And those things are important. And then the other area I worked 10 years in is the emergency room, which actually prepared me for you. because it has all those other diagnoses. And then my other part of it is newborn ICU, PD ICU. So I've got all this crazy experience, which I'm going to share. All right, let's go ahead and let's get to today's PowerPoint. Any questions? I think the one
So
that,
I was looking at along your week 4 assignment. Is that where you pulled up that assessment that we have due?
week 8.
Week 8. Okay. Okay. I don't know why I thought it
That's
said week
okay.
4.
That's okay. Week 8.
Getting on my room.
So I think one of the things that you do see with me is communication. I think that's the key thing. Talk with me, I'll help you. Talk to me after, there's not much I can do, all right? So always, always, always talk to me. I'll help you through. So 26, 27, 28, 29, 30. Lots of chapters, right? So let's break it down and let's go into what we need to know here. And then when we're done, we have a Kahoots, and basically those are the concepts you need to know. Oh, 1 second here. So chapter 26 is basically an overview of pediatrics. Now, many of you are going to go on for your BSN, MSN. Some of them might be crazy and go on for your PhD like I did. It's craziness, but you might, depending on what goes on with you. I recommend a DNP versus PhD, but it's if you want to do research or not. I'm a research kid. Anyway, one of the sites that is a great site for you to use in many different things is what we call Healthy People. I had no clue what that meant when I went back to school for my BSN. Now, I didn't go back for my higher level degrees until after 33 years of being a nurse. And that's when I realized that I needed higher degrees so that I could continue to provide an income for me and my family. So I said, all right, let me go back. I didn't know what a computer was. I barely, I'm going to tell you a little story about me with trying to save something to a computer and I couldn't do it. And I called up technical support and I said, I'm trying to save this and I'm following all the instructions my professor said, but I can't do it. So this gentleman was very patient and he said, well, do you have this? Do you have this? Do you have that? And in the end to me, he says, oh, ma'am, I know what the problem is. You don't have Office in your computer. I said, sir, I'm not opening a business. I'm going to school. Why do I need an office? Microsoft Office is your Word document, your PowerPoints. I had no clue. That man laughed so hard. And to this day, I'm telling you, that's how I started going back to school, trying to figure out things like PowerPoints and figuring things out like Word documents and saving them and sending them. And, I got to be pretty good in the end. But one of the things with those that is that you need to learn from the basics, right? If you're going to go back to school, this is a website you're going to use all the time. Healthy People 2030. And it talks about government and it talks about what their focus is. You've said Obama was all about getting out and exercising, right? And you had some about reading books and healthy people, dental health, all of these things. That we have. And in children, these are the things that we're looking for right now. Some of the problems that we know are out there today in children is obesity, injuries, violence. Vaping is a big thing. When it first came out, it was crazy. I mean, and vaping, they're vaping even marijuana on those things today. So, younger kids have them all the time. And children do have mental health problems. And I've seen some children with severe mental health problems. And that's a picture which just shows you everything. Another one of the problems, I live in South Florida, right? I live in Homestead, which is right before the Keys. So there's water everywhere. And yes, I have a pool in my backyard. So swimming and drowning is a big thing. Health problems and what are the highest risk children? Well, children that are born early, premature, with very low birth weight or low birth weight, these children are going to have more problems. They're going to be in the hospital longer. They're going to have problems maybe with their brain, cognition, with their respiratory, etc. All those things. Children in daycare. What do kids in daycare do all day? They swap their spit, don't they? From one toy, from one child's mouth to the next to the next. And as much as they're diligent and cleaning and all that, it happens. You know, when kids are all over each other. I mean, it's a good and bad thing, right? You want children to get these little illnesses so they build up immunities, but it is a high risk. Children living in poverty, homeless, it's a reality. There are children, that can barely, eat every day. They're lucky that they have electricity and water and a place to sleep. Immigrant families, I've seen many immigrant families that are afraid to go to the hospital. They're afraid they're going to be deported out. And usually the immigrant families that I used to get from down here in Homestead, there are a bunch of farms down here, when you see a child from that, and you could sort of tell, um these kids are sick and these kids need attention quickly. They usually are that sick. Children that have chronic medical conditions, they're always going to have problems. And then what about those barriers? Do they have health care? Do they have the ability for transportation to get, and even that $5 copay, do they have it to get their kids to the doctor, right? Now, neonatal children are the first 28 days of life. That's neonates, okay? After that 1 month, we call it infants. So that first month, they're called neonates. After that, they're called infants. Now, the number of deaths that can happen is quite a bit. And the one thing that's sort of sad is the United States is really far behind many other countries. There's a lot more that we can do in order to have children born in a better condition. It has to do with prenatal care, has to do with children born. I mean, I've seen so many changes done in my career as a nurse, but there's many more that needs to be done. And when you're talking about children, they call low birth weight less than 5.5 pounds or 2,500 grams. Now, death rates for children greater than 1 year of age are going to be less. They're mostly accidents. Unintentional accidents is what happens. And because now they've already gone through that first year, they've gotten immunizations, they've had illnesses, they're building immune systems, and their bodies are stronger. And from 5 to 14, it's not that bad. But look at this as adolescents. What do adolescents do? They're adults now, right? You can't tell me what to do. And they start doing things without thinking. And, they're having injuries, homicides. And you're going to find out as we go through week 3, adolescence, one of the big things is body image and depression when they're not feeling accepted by their groups. Other increased mortalities, we've been through that: homeless, poverty, low birth weight, etc. Now, pediatric nursing, and this is one of the reasons why many nurses don't go into it, it's not just a kid you take care of, it's an entire family. Families can be hard, rough, and difficult to deal with. I know every time there was a difficult family in the unit, I was going to get that family because I knew how to handle them, how to treat them, and how to make them feel involved in the care. Most of these difficult families just want to know what's going on. So it is having that compassion, and it takes time. So it is family-centered care. Because remember, the family is the only constant in a child's life, right? That's all they know. They don't know culture. They don't know anything. They know a family and what the family does and sees, okay? What is a family? Well, my Christian, when he was born, it was me, mommy, and my husband and the baby. And that was our family. I mean, I'm very grateful to say, after he was 3, my daughter found the most amazing man. She just got married in Mexico in September, and he's got a beautiful life. So now it's mommy, daddy, and my grandson Christian, and then now it's me and my husband. But what is a family? Mother, mother, father, father, adoptive. They're all a family. Whatever they say it is, that is a family. Now, nurses, as I said, takes a lot of patience and compassion, right? It's that therapeutic relationship. And I think the one thing a pediatric nurse has to do, and I think any nurse, is teaching. Whenever I touch a child and family is there, I'm always telling the kid, which is really the parent, what I'm doing. I'm telling them what I'm looking for, what I'm listening, what I'm seeing, so that they understand how to take care for their kids at home, because most parents hate giving up that ability to take care of their kids to somebody else, right? They don't want a nurse doing what they should be doing. So again, it's that teaching. We also teach about health promotion and injury prevention. I mean, injury is the biggest thing with kids, especially toddlers. I call them my dive bomb kids. They'll jump off of anything just because they can. Now, one of the things about children today is giving them care, which is the least stressful and the least physical distress. Now, one of the programs I developed at Nicholas Children's Hospital, it's a big pediatric facility down here with all outreaching urgent cares, is something called Huggies. And it's H period U period G period. It's an acronym. Help us give great injections efficiently and safely. And what I promoted and I researched and found out to be true, children that were held in a parent's arm during a painful procedure like an injection had less stress and fear before, during, and after the procedure, as evidenced by decreased crying. So Huggies is part of that psychological distress. I help them decrease that, right? And because they're held, they're not as tense. Giving an injection, they're more relaxed, right? So no harm. It's just part of being a pediatric nurse. It's and it's still today, it's still going on at Nicholas Children's. So I can say I did make a difference in pediatrics. As I said, there's all different family structures. You know, I could go on and on about the amount of them. Now, strengths of these families, we know that one of the things as nurses we need to know is the role of who in the family does what. Now, I've been in Miami since the early 80s, and my children are actually from a Cuban man. So I learned about the Hispanic culture and the beliefs. And I know that grandmas, abuelas in this culture are that person who tells mom and dad what to do and how to do, and they take care of their kids. It's just part of what they do. Other cultures are different. You have some cultures that you have to only speak to the father or to the mother or find out who am I talking to today. It could be the aunt or it could be a friend. So knowing the roles will help you teach and these families. As I said, knowing social, cultural, religious influences are important. I mean, you might see a child as these little round circles on their like ecchymotic areas that look like on the back. This could be an oriental type of cupping with the glasses, the glass cups, and they stick them to them to pull out the bad jujus on them. Um, or it could be incense, all different things that are differently, that are done different. And as nurses, we don't need to know it, but what I have found out through different cultures and not understanding at all, I'd say, so what is this? Where did it come from? Or how would you do this? Tell me, what is your way? I don't know your way. And I have found that parents, even children, are feel better and are better towards me when I'm the one who says, I don't know, tell me, teach me your way. I mean, we see a lot of different things and a lot of different influences but asking that parent, that child is the big thing. We know that there's many things that influence the child. Remember to say that here, your child's being sent home, they're going to have physical therapy on these days, da da da. Well, do you know that they can get to those appointments every day? Do they have the transportation? Do you need to get social worker in to make sure? Or do they have the ability for co-pays? Da 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 da. I mean, all of these things, yes, nurses take care of patients and do nursing care, but it goes beyond that. There's more than just today. There's always making sure that child doesn't come back because they didn't get the care that they needed at home. You know, it's making sure that they have their ability to practice their own religion and spirituality. And sometimes it's saying, okay, what time do you need for your what you need to do, and I'll come back later, or I'll work my schedule around you. I'm telling you, parents and children are really, really they like that. They like that you work around them, and it's a lot of respect, and then they respect you back. Frequent health problems of migrant families and adolescents in the United States. And number one here is tuberculosis. And in the United States, we're always tested, right? But coming from other countries, remember, there's different health care. So to be aware of these things, you get a migrant in with respiratory symptom, put a mask on, right? It could be tuberculosis. Cultural beliefs. Now, one thing I had a hard time with, and I really, really didn't understand. But as being a nurse down here since, the mid 80s, I started to really learn about what is needed and understanding things. For instance, there are cultures that don't eat meat. There are cultures that they don't undress themselves. There are some cultures that a female cannot have a male nurse. There's many different things that we need to understand. Some of them have a bunch of homeopathic remedies that can affect medical care. So understanding that. I mean, my husband today, in fact, we just celebrated 20 years, is he's Jamaican. And in that culture, there is a lot of homeopathic teas with ginger and garlic. What do you know about G's and what do you know about pharmacology? Those homeopathic G's are anticoagulants. What if I had to be put on Coumadin? It could make a difference. So understanding that, and it takes time. You're not going to learn it in a day, but keep your mind open to these abilities, okay? Remember, there are rituals, there's things that they're going to do. And again, if they need time for prayer or they want the medicine man come in to do some sort of whatever, as long as it doesn't interfere with medical care, why not? Mentally, it will help them, right? Now, have you ever heard if you go to bed with wet hair, you're going to get sick? Has your grandmother ever said that? Or if you go out in the rain and you get wet, you could get sick. I've also heard that if you walk on a cold floor without socks on, you're going to get sick. That is real, real Hispanic. And to understand these things, and this is that hot, cold thing. Now, what I have told, especially remember, grandma's the big person here, right? And grandma always goes to the hospital with their children, their grandkids who are sick. And I'll say, Grandma, do you make your child put on socks to go around the floor and they're in there with a fever? They go, why, of course. I said, well, let me explain you something. When you take hot and you hold it in, what's going to happen? Child's going to get hotter. And when they're hot, they don't want to eat, they don't want to drink. So there's things we can do. If they are with no socks on, walking on a cool floor, and most floors here in South Florida are ceramic tile, right? That coolness will pull the heat out and help keep their temperature down. And they go, oh, because they want their kids to eat, because they always chicken soup. They got to give them their chicken soup, right? So understanding the culture and putting it in context for them can help them. I actually did. I don't know what it was. It was actually in an adult world, but I'm going to tell you, I was pregnant at the time, so it's quite a long time ago. And I was in the I was a nursing supervisor. I was in the ICU, and this family wanted to take chicken and blood and do something, I don't know, behind a curtain. I mean, it wasn't going to go on them or in them. It was just this whatever they wanted. And I was pregnant, and they said, "You need to tape a quarter to your belly button. Here's the quarter." I'm like, "All right." I taped it on. And I said, "Why?" Because, well, we don't want the evil spirits going in there to your baby. And they did whatever, whatever, whatever. This man was very sick, post-op, bowel obstruction, really, really ill. Do you know the next day he was better, and by the following day he was back on the floor? He turned around with it. I don't know if it had anything to do with this blood and chicken and these whatever they were saying, but it worked. So it didn't interfere with me. I let them do it. And again, what respect did I have there? We gained respect with that gentleman there. Another thing is giving a child the ability to be baptized. Now, working in the cardiac ICU, I had many children who would come in and they would be very ill. It could be one of those really bad heart conditions. And, they'd say, "Can we baptize the child with whoever they wanted to baptize with?" I'm like, "Absolutely, why not?" And I'm like, "Do you want us to call one of the hospital people in, or do you want your own person?" And I would arrange it, call social worker up, they would arrange it, let them have it. Now, what happens if your child needs blood, especially when you have a premature infant in the newborn ICU? And these children do not start making their own blood till about 6 months. So it's 3 to 6 months, all right? So their hemoglobin and hematocrit are going to go down, down, down. Especially if you're taking blood to monitor things like electrolytes and a CBC every other day, right? So you're taking blood out, nothing's going in, and all of a sudden, symptomatic would be apneas and bradycardias. They'd stop breathing and their heart rates would go really low. And that's telling us they're symptomatic, they need blood. And they're Jehovah Witness. They don't believe in giving blood. They believe something about the soul of the other person is going to be entered into their child, and they cannot sign for it. And you need a consent. Well, that's when we'd have our hospital person come in and get the court order, the risk management, get the court order, and then we could give blood. Now, am I going to wave that blood bag in front of those parents? Absolutely not. Now, I did a lot of night shift, actually 23 years of nights I did. And the one thing I did was, if I could, you go home, call me back at this time, I'll be done, and then I'll go and I'll put it all up, the tubing, etc., and give it. And they call me, "It's finished, your kid did well." I've also been on the day shift where I had to do it. So I put the parent out of the room and I pulled it up, put it on the child, covered all the blood tubing, didn't leave the bag hanging out anywhere, and then would just look at the IV site underneath a blanket. Never put the blood in their face. And those are little things you do out of respect. Now, going back to that Jehovah's Witness and that day shift time, it was a child who, it was the last day I worked in the ER, came into the ER, and I knew the name. And when I saw the diagnosis, I went to say hello. She actually said, "I've been looking for you to thank you for the way that you treated my child." Now, this is 18 years later that she's saying this to me, and that it really made her feel like I understood her. And her kid was 18 and looked amazing. So little things that you do make a big, big difference. And it took a couple extra seconds to cover up the blood and to ensure it wasn't in their face, because that is their beliefs. Again, food, not having pork, not having beef, not having meat, vegetarian, etc. And of course, all those natural remedies that I was talking about. Nurses, I think a lot of we're the counselor. We're the counselor between parents. We're the counselor between child and parents. and again, it's making sure that we are giving the kid what they need and respecting. Now, leading cause of death among African American boys, ages 15 to 19. What would you say?
Suicide?
Remember, these are the risk takers. Firearms.
Yeah, I was gonna say firearm.
Firearms, and then after that, I would say suicide. Firearms is actually more because all of a sudden they feel like, oh, this is a gun. I'm old enough. Let me look at it. And then somebody gets hurt, right? And you hear those stories on the news. All right, genetics. Talking about kids growing. Now, next week, we're going to go into infants, toddlers, and preschoolers. And we're going to talk more about growth, development, what you're going to see in them. But remember, when a kid is growing, it is interrelated, simultaneous, and ongoing. A child who gets proper nutrition is going to grow because their fuel to their brain is getting what they need, and you're going to see them do their gross motor skills, fine motor skills in that way that they should be doing. And as long as their development is going forward, they're doing well. And what do I mean by that? Well, according to the book, by 12 months old, they should be walking. Well, not every kid is walking by 12 months. Some of them are walking at 9 months. My kids and Christian did not walk till 15 months. And they didn't walk, they ran. They did 28 steps the first time. And I call that running. I don't call that walking. And that as long as they were turning over, standing up, all of the things they're supposed to do, but they weren't quite walking. They attempted and fall. As long as they're going forward in the pattern, we know they're good. Now, if they're not, then we have to figure out why and go ahead and institute maybe some early intervention. So this is just some type of information, growth, development, maturation, differentiation. It's just saying how we move and how we mature. Now, there's ways we can also, and there's a lot of different terms here. So how do we grow? Well, we look at things like the first thing a kid does in their motor skills. They lift their head, right? Then they turn from their bellies to their back, about 4 or 5 months. And by 6 months, they're going from their back to their belly. And then all of a sudden, they're up on their knees and they're crawling. And then they're up on their feet and they're creeping. And then by 12 months, they should be at least attempting to take a step. This is all motor. Fine motor, F is fine for fingers, is all about that reflex, palmar grasp. First thing. I'm going to go more next week about it, but just introduce you. Then it goes into, a rattle. I know what that is, and grabbing it. And then it's that going to those little Cheerios, those little puff things on their high chairs, right? First of all, it's like a smush in, and then it gets to be what you call a crude pincer grasp. Then it goes to a pincer grasp. Then it goes to putting blocks in a container, and then building a block of 2 stacking up together by 1 year old. These are things that they should be doing. Sequential is that lifting their head, turning over, crawl before they creep, etc. And remember, some kids skip steps, and that's all okay. All right. And those sensitive periods are periods where nothing much is going on. All right. Now, another thing, I did send out a vital sign sheet. And if you noticed it or not, there are different vital signs for different levels of children. Infants, the neonates, their normal heart rate is 140 to 160, and respiratory rate is 40 to 60. At sleep, at rest, relaxed. What is ours as adults? 60 to 100, 12 to 20, right? So you need to know the difference in vital signs. And it's usually when we talk about things like administering digoxin. How would you know if it's too low, right? Or if it's not high enough? It is understanding the vital signs of different sized children. And that's part of the metabolism. When infants are born, they do not regulate their own body heat. That's why they have hats on and we wrap them up tight and put them under warmers. And as they get older, they'll need less and less clothing on. When they're born, they sleep a lot. As they get older, they sleep less, right? And the biggest influence on growth, cognition, development is nutrition. Making sure that infant is getting proper nutrition, whether it is that breast milk for the first 6 months or iron fortified formula for the first 6 months, making sure that they are getting proper nutrition. Well, then I ask you, how do you know if they're getting enough nutrition? Well, what do you do every time a child goes to a doctor's office or into an ER, urgent care? We do a height and weight. We look at previous numbers. If it's not getting more, there's a problem, right? Or if they're not doing their motor skills, if by 6 months old they're not turning front to back to front, something's wrong. They should be. Or you pick them up and their head falls to the back, called a head lag, and they should have control by 3 months old. There's something wrong. That could be improper nutrition. So it's looking at the numbers of height and weight and looking at where they are cognition developmentally, okay? We know all children are different. You know, we have that first kid who was a breeze and that second kid, oh my goodness, there's nothing you could do and they want all your attention, right? That is all kids. Now, one of the hardest thing in pediatrics is all of your theorists. And it's something that you're going to have to look at and try to understand in your way. Now, YouTube has a lot of different things on these. I can post some of them for you. I did send you one handout on the theorists, and I will be going over them more next week, okay? But if you think of theorists, think of different levels of children. You have infants, toddlers, ages 1 to 3, preschoolers, ages 3 to 6, school ages, age 6 to 12, and adolescents, 12 and up. And each group of children should be able to cognitively do or physically do, socially do something else. Okay? And if you can remember that, you'll be okay. We do the first four: Freud, Erikson, Piaget, Kohlberg. We don't really do Fowler, but we mention it here. It's just the understanding. I sort of infuse it into the others. Freud. What do children do at birth? What's the first thing? Fingers in the mouth, right? As they get a little bit older, toes in the mouth. Take a rattle, rattle in the mouth, right? Pacifier. What does a child do with a pacifier? It's called, as my husband, my Jamaican man, says, it's a soother. Yes, they can self-soothe. That's how they soothe themselves and calm themselves down, through their mouth. They explore the world through their mouths, okay? Then next step, toddler, ages 1 to 3. Potty training, so it's anal stage. 3 to 6, now they have found their genitals. That's the phallic stage. Latency is all about relationships with people, okay? And then themselves, what they do good, what they don't do good. And then genital, of course. Age 12, we know it's into, sexual, same sex, different sex, whatever it is, in relationships. Now, Erikson is probably the most tested of all. And initially, it's all about trust versus mistrust. Well, what does an infant do to get your attention? They cry. And when they cry, what happens? Somebody goes gets them. That's trust. And their needs are being met. Now, what if that infant cries and nobody goes and they don't get their needs met? That is mistrust. As we get on to toddlers, toddlers are the me, mine. They're all about themselves, egocentric, which means all about me, okay? And then you have that adult that's saying, be careful, don't do that, don't jump off that, get down from there. You're going to hurt yourself. And don't let them try to do stuff because they don't want them to be hurt. That's the shame and doubt. And it goes onward, and I won't go into it completely because it's going to go over your head today. But these are things. Try to figure out which way you can learn them. Piaget is all about thinking. The sensorimotor is finally they have that, voluntary grasp and they get a rattle. And all of a sudden they shake it and they hear a noise and they go, ooh, I like that. Right? Is how they learn to do things. Because remember, they don't know how to do anything at birth. They sort of have to self-teach, or we have to teach them about these sort of things. Pre-operational, they throw their bottle on the floor and they're in the high chair. They know somebody's going to come get it and pick it up because they wanted their mommy, right? All of these things. Language, we know that they're born with cooing and crying. That's what they do. And we know that from there on, they learn how to communicate their needs, don't they? Whether it's through physical, what they do, or through their language. And remember, they don't know how to express themselves really well at first. It's when they start to talk, maybe by preschooler. And Kohlberg is all about morals, all about right and wrong. And we'll go into more again about that next week. Now, what do kids do? I mean, even us adults, when we have time, right? We play, whether it's on, the computer, on your phone. Kids, they wake up and they go directly to the toys, right? Young kids, toys in their mouth, and that sense pleasure, right? Or getting in the sandbox or feeling that sand, or that little toddler going out in the mud and squeezing it and getting dirty everywhere. These are things how to play. And we need to know that play is important. It teaches them things. Very important. Now, there are several sorts of play, and you need to know the types of play. Onlooker play is when a kid looks at another kid, what they're doing, just watching. Solitary play, they're playing alone, solitary, right? Toddlers, they don't like sharing, do they? Me, mine. It's called parallel play. They're both playing with toys, but they're not sharing at all. Then it goes on into associative play, where they're all playing with the toys. This is more preschoolers. They're all playing with all different toys all together, but there's no rule. Nobody wins. They're just playing. Cooperative play is when there's a result, whether it be board games, somebody wins, or they're building a castle and they finish building the castle or their house or whatever. Or they roll the car and it has to get all the way to a certain point. This is cooperative play. There's a result. Associative, there's just playing all together with things. Parallel, not together at all. And then you're onlooker solitary.
What was your example for onlooker?
They're just sitting there looking at the other kid. They're not sharing. They're not doing anything. They're just looking. Toys are great. We know it. There's all these age groups on there, right? For kids up to age 3, up to age 4, right? And we always look at those things. And it's because we're trying to promote something. And we know that taking toys, especially when they're on their tummy time, right? And they see their toy up ahead, they're trying to wiggle to get there. And that really helps with that pushing, pulling, rolling movement. That's muscle development, and they're seeing it. It's cognition. Now, developmental assessments. I sort of mentioned about how we need to know what kids are supposed to do. And if they're not doing it, there's many times I know that my 2 oldest kids had speech therapy because they weren't speaking as many words as they should. They couldn't express themselves. So she went in, they were evaluated, and they both had speech therapy. And they're both fine today. They both speak really well. It could be also something with their neurologically, their head's not holding up, or their muscles are weak, or they might need physical therapy, occupational therapy. But the earliest that we can institute the better they do. And the great part about kids, the earlier you institute it, they catch up really quick. Kids are resilient. They don't know they're behind. You just show them things and they start doing it. And kids with disabilities, you think, I mean, years ago, when I was a senior in high school, I used to work for um, this association. They had cognitive delays. At that time, I was 18 years old, a long time ago. They called it the Center for Retarded Children, believe it or not, which is not heard of today, but it was back then. That was the name. And I used to go volunteer. And literally, we would get the kids out of bed, dress them, feed them, put them in front of TV. They weren't really occupational speech or physical therapy. Today, we are teaching them how to know colors and circles and, understand a lot more and to be able to speak. Those of you that are going to go to Cutler Bay down here in Miami, you're going to meet my favorite little kid called Jonathan. And he's a 7-year-old kid with severe spastic CP. And that kid has a screen where he can talk to you. And years ago, that wouldn't have happened. So we do all of these things to make these kids be more than we ever thought they could be before. We know kids are born with all different sort of things, club feet, cleft lip, all of these, and they're all due to many different things. I mean, I've seen children born missing lower arms, lower legs, etc. It's all due to different things, whether it's genetic or due to maybe drugs, etc. We know that when we're talking about problems with genetics, we need to understand that parents might need to go through testing if they want another kid, and to make sure that that next kid they have the possibility of having that. We know that chromosomes are big. Q22 deletion syndrome. I'll never forget it. It's called the George syndrome. And it has to do, and it's telling you what you might see in that child. We also have, of course, those things, rubella, chemicals, radiation, and of course, PKU. That's what those little circles are done at birth for. But we can figure out by previous children what we need to do for them. So again, when we are a nurse and we're taking care of these kids, again, a lot of our stuff is education, and we're going to start finding out as we start going to children and getting on their level and playing with them, because it's what we do when we take care of them. We're teaching them, teaching parents how to best take care of their children. Now, this is a question. It has to do with a concept here. And it goes that the father tells the nurse that his child is filling up the house with collections, seashells, bottle caps, baseball cards, pennies. And the nurse should recognize this as what? Now, I have them listed here and what the answer is. Those things. Object permanence is something that you're going to see again. Object permanence is you show a kid, even small infants, this, let's say it's a teddy bear, and then you put it underneath a blanket. That kid still knows it's there. What about the older kid? You take his cars, put them in the toy box. They're out of sight, right? The next morning they wake up, they're going to go to the toy box and get their toy, right? Object permanence. Even though it's out of sight, they still know it's there. Pre-operational thinking, again, we're going to go into that more when we start talking about Piaget. And concrete operations is just the ability to put same things together, same colors, same shapes, same cars, trucks, different things like that. So histories and physicals, remember, even kids, there is HIPAA. Be careful when you work with children. And this is the one thing that I had to remind myself. If a child is 18 years old and cognitively aware, this child is in control of their medical care. You must ask the child permission if their parents listen to what's going on with them. So a parent could go on the outside with you. So how did those lab tests come back? And I'm saying, well, I can't tell you. I will tell your child, or I need to get permission from them to tell you. Some of them are offended, but again, it's the law. Be careful. Communicating with parents, I said sometimes it's hard. Now, I had a I remember starting in the emergency room, and as I said, I worked with a very large Hispanic population. And Hispanics tend to bring a kid in, and they're with 6 other people. It's just their culture. So many of the times, mom hasn't had their kid all weekend. It was the aunt, the grandmother, whoever. So making sure you say, so who's going to answer the questions? And making sure they tell you about what happened this time, which is directing the focus. Like what happened this time? Not at birth, they were in ICU for 2 weeks, and no, they're 6 years old now. What's going on now? The only reason why I would know about birth if they had some sort of birth defects. Again, listen. And silence is big, big, big. This cultural awareness, there are some cultures you can't look in their eyes, especially men, looking in their eyes, they take it as disrespect. And there's some cultures who won't look at your eyes because that is considered disrespect, just knowing those things. Um, and one of the things I used to always do, especially with the young infants coming in, and the kid's been sick for a week, I'm going, Mom, you must be exhausted. They've already gone to the doctors twice, the urgent care, and now their 4th visit, they're at the ER and they're working. I'm like, oh my goodness, you must be exhausted. I said, what can I do to help you? And you know something, you're going to see those shoulders relax and feel like, oh, this woman understands me. This nurse gets it. And then again, doing what you can to help that mother get through it. Say, why don't you go get a cup of coffee? Let me sit here with your child for a second. And some of them, that's all they need to hear. And sometimes it takes 10 minutes. And that 10 minutes will make your whole visit with the child and this parent so much easier. Again, if there is a problem with language, never go through an older child's interpretation, because remember, they're going to put it in their understanding, not an exact type of the way that they're going to translate it for you. They have these blue phones all over the place now, so use them. Talking with kids. Now, you get a 3-year-old kid, 2-year-old kid. Number one, they're afraid of you. They're going to cry. They're going to sit in mommy's lap. Good. Let them sit in mommy's lap. What I would do is, even that woman sitting in that bed, I wouldn't be sitting up that high. I'd be sitting in a chair next to him so the kid looks down at me. Now I'm not threatening. And then I would go with, wow, you got a Batman shirt on. Do you like Batman? I would do something. Or, oh, wow, look at those freckles. Or you've got big eyelashes. I mean, something the kid that they would understand. So now they feeling a little comfortable with for you. Older kids, 4 or 5, are you in school? What do you like to do at school? Well, what's your teacher's name? So now I'm not becoming threatening. Okay. And I'm explaining everything on an appropriate developmental level for that child. Most important thing you can do is take those 2 or 3 minutes, ease up their tensions, get on their level, and I'm telling you, these kids then will open to you. And I'm always doing something to play. I would always, as a pediatric nurse, carry stickers in my pockets, whether it was SpongeBob or princesses or Batman or whatever. And that is an opening for these kids, and they will listen to you. As I said, history taken, find out who you're talking to. They could have been with the aunt all weekend, talk to the aunt, not to the mother then, right? And then figuring out what's going on. These histories we go over, any birth history would be something that still today, they were premature at birth. Okay. Any respiratory issues? No. All right, good. Of course, allergies, medication, immunizations are very important. If a kid who's 3 years old comes in who has a respiratory illness, who has had no immunizations, you better put a mask on too. It could be something like pertussis, right? So you need to be careful because it is around for those children who don't get immunized. And again, looking, are they up to where they should be with their growth and development? And the habits, I want to know if they're being admitted to a hospital. I want to know what their habits are. What's their favorite toy? Younger kid, what's their favorite pacifier? Or they have a blanket. What, in case you have to leave the room quickly, what can I get the kid if the kid's crying? How can I comfort them? Adults getting sexual histories. Many times, the adolescents, I will have the parents walk out of the room. And again, I have to break open some sort of rapport with them. I might say, "Oh, I hear you're listening to some music. Who do you like?" I'm like, "Okay." Or maybe they have these really cool sneakers on, the newest brand, and I'll mention it. Anything. Or are you going to college? Have you picked one out? Oh, I see that you have a Yankee shirt on. Are you a Yankees fan? I mean, you don't like the Marlins? I mean, something. Break it open. All right. Parents out of the room, listen to them. Adolescents will try to shock you. They're going to tell you some crazy things, and they will. So just be aware of that. Don't try to, keep a straight face during it because sometimes it's like, okay. But sometimes it can answer why they're having frequent urinary tract infections because they are having sex, right? And there's things you can do to help them. Always understanding the family, understanding things like the parent-child relationships. And this one drives me a little bit crazy at times because parent-child relationships, where I worked in the ER, they had single rooms for each patient. And they all had a stretcher, they all had a little bedside table. Inside them would be swabs and alcohol and maybe cultures. And then, of course, you have your otoscope, et cetera, the little black little thingies up top. And you'll walk in, and the drawers are open, stuff is everywhere. The otoscope's on the floor, and the kid's just sitting there, and the mother's on their phone. And you're like, okay, we really take care of our kid well. So now you have to take control of the situation. Or try to give a patient medication. No! And try and have the mother give it, and they don't know how to give it. So these things, when they go home, you think they're going to take their medication if they're not going to take it in the hospital? Maybe not. So you've got to really look at these sort of things. When you have a kid admitted in a hospital, you need to know what they need to eat. If they are celiac disease, or there's certain things they can't have, taking it off the tray before it goes in. If they are a vegetarian, you don't want them to have a plate with bacon on it. I mean, for breakfast. So knowing these things. Again, nutritional assessment. Again, cognition, height, and weight. We can figure it out. Now, in adults, how do you do your assessment? You do head to toe, right? In children, you don't. Number one, you try to get that focused assessment, as in they've come in with a cough. So, first of all, I want to listen to their lungs, right? If I can get it done. If they're asleep in the mother's arms, I'm going to listen to their lungs and their heart while they're asleep and do as much as I can when they're quiet. And I may have to put something off to the end, but you will do it in a manner, you'll get it all done, but it's never, never, never head to toe. You try to get what you need to know first, quickly, and then the rest, we'll get it when we can. All right. Preparing kids, always. You think young kids don't understand. They do. I mean, we're lucky today they have this thing called Child Life. And Child Life will come in and play with your kids. We'll show them what an arm board is. Show them about the little numbing spray that we have. They will show them the tape and et cetera, et cetera. And when they know what's happening, these kids do a lot better. Okay. And always I keep the parents involved. The only time the parent wouldn't be there is, for instance, like with a spinal tap. where it has to be sterility, because we don't want any problems with infection. So examining the kid again, always have a kid explain them and let them know what's going to be going on. Now, when we look at the whole body, it's a lot of stuff. Now, the things that you need to know here is when will you do head circumference? When you're going to do an abdominal circumference? Well, all infants, you're going to be doing once a day head circumference because you're going to be checking to make sure hydrocephalus, right? Hydrocephalus, water on the brain. So we want to measure it. We're going to do abdominal circumference, making sure they're eating their food and it's being absorbed into the body, right? We're going to be checking apical pulses on these children. They say up to age 5, you should be doing apical. And remember what the numbers are. If you have an infant with a heart rate of 80, you have a problem, okay? Which would be an emergent problem. So again, knowing your numbers. Blood pressure cuffs, I like on your toddlers and your preschoolers to put it on the lower leg, on their calves. It works better. They're less stressed with it, and you still get a great blood pressure with it. And remember, there's different sizes. Looking at their ears, nose, mouth, abdomen. Is it rounded? Is it loopy? Do you hear bowel sounds? And genitalia is a big thing. You will see a lot, and more than I ever expected, of fused vaginas. The lips are fused, where it's really hard to see if you need to do a catheterization. And it's called fused. And all they do is put some hormone cream on it and it opens it up. But expecting it, knowing it. At birth, we always check for an anus because you can be born without an anus. That's why they do a rectal temperature at birth to make sure. Reflexes. I used to let the kids bang on my knees and elbows and whatever they wanted. And then it became fun. Again, doing head, chest, abdominal circumference. Remember, at birth, their heads are bigger than their chest by 1.5. Their chest should be bigger than their head, or at least minimally equal to. And their abdominal circumference, we're going to do it on those kids as they get older with problems with their abdomen. It could be that they had a problem and needed abdominal surgery, or they're young, premature infants, making sure that their food is being absorbed properly. And if it's not, things we need to do. Taking a height on a young kid can be really hard. They think that little thing coming down is going to bop them on their head and hurt them. So I make it into a game. Usually on the side, there's going to be a little number, right? So I said, I'm going to be a number 7. Let me see. And I go, oh, there it is. What number am I? And they go, oh, number 7. So I said, okay, now you hold it, put it on the top of your head. Oh, look, you're a number 8. You're bigger than me. And now I made it fun. I got an appropriate height and it was no big deal. And this thing, they'll be running out of the room when they see these things sometimes. Again, blood pressure cuff should be put on properly. Again, I like D for your young kids because it works better. I think upper arms, it pinches me. I don't like it, but it pinches the kids too. And then the one thing probably is my biggest thing and pet peeve in nursing, especially pediatrics, is the undermanagement of pain control in children. I think children suffer from it. And it's because they don't want the medicine and they don't want that injection. So they'll say, I'm not in pain. Or culturally, daddy might say, suck it up, kid, you're fine. You're not in pain. You don't need anything, right? That's what some male machos might do to their sons. So many times these kids are in pain. It also could be because we're not asking, but today we have that 5th vital sign is pain. Give me a pain scales. And there are pain scales we use, and I'll be going into which ones you need to know about. We think that giving less than what they need works. No, we know what doses can be given, even with morphine. Is probably one of the most controlled narcotics because we've worked with it forever and ever and ever. We know. And making sure we don't wait too long in between. And always go back and ask, did the medicine work? So the ones that we use, the three that you need to know are faces, FLAC, and numeric. There's just other ones here, all right? Now, numeric is used by children 8 and older, according to the book. Now, have I had younger kids give me a number? Yes, but according to the book, ages 8 and up is numeric. Now, go to the bottom. FLAC, faces, legs, activity, crying, consolability. You can use that for nonverbal children also. I've used this for 18-year-old cerebral palsy children that are nonverbal. And it works, okay? And it will give you a score. And according to the score, you need to give some sort of intervention. And then there's faces. And faces is this little number right here. And this is mostly used in the pediatric. And the best thing about children and what I love is they don't over exaggerate pain. They will tell you exactly how they hurt. And they will point to the pictures right here. Know that there's all different types of pain. There's that chronic pain. It could be sickle cell, right? It could be, acute pain could be, teething. Persistent pain could be maybe they need surgery, right? All different pains. Remember, chronic pain, if it's left untreated, can cause a lot of problems. Can you imagine a kid who's always in pain, how they would feel? They can't do what other kids do. So emotionally, they wouldn't be good that way. Now, non-pharmacological management. You think pain, you think, got to give some medicine, right? Well, what if it's, you just had a kid come back from surgery and they had an appendix done and their bed is flat. Elevate the head of their bed, right? So they're taking the pressure off their abdomen. Give them a pillow for their tummy so that they can cough. Maybe it's sickle cell. You need heat, you need cold. Rheumatoid arthritis, same thing. So sometimes music, I have found, is one of the biggest pain controls. Turning on music and, just dancing with the kid. And let me tell you, it does really relax them. And one of the other things used widely for many different reasons is distraction. Give a kid a video game and they forget they're in pain, don't they? Or they forget they're in a hospital. They get so involved in their games, right? And yes, it should be used for these children. And that little mother right there is doing something called kangaroo care. It's called skin to skin. I have seen many of a premature infant on the warmer in an isolette, just irritable. They can't get comfortable. Their heart rates and respiratory rates and blood pressures are up. Mommy comes, I put them on the skin. They go to sleep, their heart rates come down, their blood pressures come down, and they're relaxed. The best that they've been all day long. It works well. And again, that pacifier. Pacifiers are the biggest thing. Christian was born and had a really tight foreskin called thymosis. And even I couldn't pull it down. Okay. So we went to the doctor. He goes, no, yeah, we need to circumcise it. They did it in the office with a pacifier with a little sugar water. It has been proven, and I've done the research on this, by a Harvard neurophysiologist on pacifiers and morphine, and if there was a difference in pain control, and there's nothing. They said the pacifier with sugar water or morphine worked as the same pain control. So it works really well. So they firmly believe in pacifiers today. Remember, there's just not narcotics. They're just not things you can do. Remember, there's also things, like Tylenol and Motrin. Remember, ibuprofen, Motrin cannot be given till they're 6 months old. Okay? Before that, it's only acetaminophen. You could give morphine to a kid who's 1 day old, not a problem. but you cannot ibuprofen. And the reason, and I've asked why, has to do with some platelet bleeding coagulopathy things. So they don't want it given earlier than 6 months old. Remember, there's those PCA pumps on older kids. They can push their own medicine when they need it. And we do use those on children. And of course, again, all of this with a distraction, all of this with repositioning, etc. Now, this girl is smiling and she's got a tegaderm with this white goop there. That is a numbing cream, probably called Emla cream. And she's smiling because she's getting her blood drawn. But she knows that with that Emla sitting there, her skin is numb. So she's going to feel them touching, but she's not going to feel any pain. And in pediatrics, we do all of these things to help decrease the amount of pain they'll have. So a kid's not going to be afraid to go to the doctor, go to the hospital, right? Because they know that everything will be done to decrease the amount of pain. Pain in children, when do they have it? Well, teething, of course. Immunizations. I mean, at 2 months old, what, we get 4 or 5 shots into both legs? I mean, there's things we can do with that. As they get older, can we use Emla? Can we use numbing sprays, coolness, whatever? And yes, we do use those things. We know it could go further. Headaches, braces, I don't know, ibuprofens, all of these things can be given. And, I have seen older, not older, but children who are cancer and they're on, their end of life, they're in hospice care. They do give really good medicines to these kids and making sure that they get all the comfort that they do need. And remember, it's just not the medicines, it's also you and how you treat that kid. So, which of the following is an important factor to consider in understanding pain experienced in children? What do you think? Children in pain. What did I say about kids in pain?
I would say maybe A, they can't really tell you exactly where it hurts. They just know it hurts.
No, they know. They know it hurts.
I'm gonna go with
I say
yeah,
D.
Nope, they have the same pain as adults.
B.
See?
They don't admit it. You know why? They don't want the medicine. They don't like medicine. They don't want a shot. That's not uncommon the way that you guys just said that. Anyway, that is lecture today. A bunch of different stuff, a lot of different comments there. Has everybody done a Kahoots before? Yes? Okay. I think there's 35 questions and we'll be done. So if you take your phone and you take that little thing and you click on it, it will go right to where you need to go. That little UPC or whatever it's called. So who wants to win today? After a while, it becomes who wants to win? And it becomes very competitive. Now, this is something I'm not going to look at and I'm not going to mark you down for. I want you to try to do your best. And as you're missing questions, write it down so that you know it's something you should be looking at, okay? Again, it's a guide to help you. All right, let's get going. So we're out just about where we need to be on time. Week 1. From a worldwide perspective, infant mortality in the United States. Are we good at it? Are we doing everything we should? Are we better than everybody or not? I think the two that are actually the best, I believe Norway, Sweden, if I'm not mistaken, are the best. We have a higher mortality than many other countries. There's a lot more that we can do. So we're going to keep trying, right? Who knows? Maybe one of you will be an advocate for that in the future. The leading cause of death from unintentional injuries in children is. Now, I throw in questions from next week in here. And it's just because I want to get you understanding the concept. You know, unintentional injuries, injuries that happen because it's nobody's fault. All right. And it doesn't matter the age of the child, it is always motor vehicle. Whether they're in a car, not strapped in the car properly, or they're facing front instead of back, or they're in the front seat, not the back seat, all of these things. And as they get to be adolescents, they're driving the cars now. So motor vehicle, unintentional injuries. Which statement is most descriptive of pediatric family-centered care? What does that mean? Family-centered care. I've had many students tell me I could never be a pediatric nurse because I couldn't deal with the parents. It recognizes that family is the constant. It's all they know. They don't know how you or anybody else does things. All they know is what their family is. It's their whole world. The major cause of death for children older than 1 year old is? I turned the question around on you.
Yeah, diabetes, buddy.
Where's that? Right there?
And it's unintentional injuries. You know, older than 1, these are toddlers. And as we get into next week, as I said, the dive bomb kids, they do things that you're like, I don't believe the kid did that. The nurse caring for the child in pain understands that distraction So distraction is good, right? It can help to relieve the pain, but if it's not developmentally appropriate, it's not going to work. So it must be on that level of the kid. This is a concept of children to give them things on their level they understand. Kids are smart. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? Remember, I gave you the 4 sorts of play. Who would know play would be so important, right? And it's called associative. Solitary is alone, parallels your toddlers, next to each other, but not together at all. Associative, they're all there together, playing with all the stuff together, but there's no goal. There's no one who wins. And cooperative play, playing together with a goal, whether it be a board game like checkers or putting Legos together, making a house or whatever, right? That would be a goal. So associative. Which statement best describes the process of critical thinking? Remember the first day they talked to you about nursing and it's all about critical thinking? And you're like, what does that mean? Like, what does that mean? Well, I'm going to make dinner. I go and look, do I have the ingredients to make it? Okay, that's critical thinking. I go to the store. How much can I spend? Well, this much is in the account. That's what I can spend, right? Critical thinking, it's that easy. Remember, it's what you want, and that's your goal that you want to take. Purposeful and goal directed. What is probably the single most important influence on growth at all stages of development? Nutrition, 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 nutrition. Remember, growth. Growth is needed. You need gasoline to go, right? You need food to grow. Same thing, nutrition for cognition, for movement, for understanding. Frequent developmental assessments are important for which reasons? Why do I need to know if the kid's walking or crawling or turning over, lifting their head? Why do I need to know that stuff? We know that if there's problems, we know where you should be. And if not, there's a delay. And if there's a delay, what are we going to do? Whether it's speech, we're going to give speech therapy. If they're not moving the way they should, they're not lifting their head yet, physical therapy. And what I said, children are so quick and so resilient, they catch up quickly. Which function of play is a major component of play at all ages? What is it all about? Why do we need to have blocks? And why do we need to play with sand and paint and all of these things? What's it for? It's all about touching, and remember, sense. It's all about what it feels like. Remember, we explore the world in our mouth, oral and motor, moving it around all over and playing with it. Could be a rattle played as an airplane. I mean, there's all things, and it's all about being creative and intellectual development, but it's sensorimotor activity that does all those things. 3 children playing a board game would be an example of what sort of play? Called cooperative play. Good job. Associative, no final goal. They're just playing. There's no end to it. No winners. The head to tail direction of growth is referred to. So remember, we start with lifting our head and it goes to the end of their motor development is walking. That's head to tail. It's also called what? Well, another word for head is cephalic, right? So cephalocaudal, head to tail, all right? Proximal-distal is when they start from their inside and they work out to the periphery about seeing things. First it's here and there's fingers and stuff, and then they work out into the periphery, and that's the proximal-distal. What is the single most important factor to consider when communicating with children? You're going to sit down with a kid and you're going to talk to them, maybe about a procedure they need to get done. What do you need to know? How are you going to talk to these kids? And it's their developmental level. You're not going to talk to a 1-year-old like you talk to an 8-year-old. They're going to be different because the 1-year-old is not going to understand how you describe it as an 8-year-old. What 2-year-old pain assessment tool should the nurse use? Now, you have FLAC and you have FACES and you have numeric. FLAC is those children from ages 0 to 3. FACES are 3 to 8, and after 8 is numeric. These are questions you actually are going to see on HESI and NCLEX. You have your FLAC and you have your FACES. FACES you have to point to. FLAC is not just your young kids. Remember, it's the nonverbal children. Usually you'll see this with cerebral palsy. They can't speak, but you can see their faces, legs, activity, crying, consolability, okay? And FACES, they'll point to it. And numeric is after 8. At 6 months, an infant's birth weight should do what? Haven't told you yet. Again, this is something for next week, but again, just introducing. Part of growth and development. And are they getting proper nutrition, right? It doubles. At 6 months, an infant's birth weight should double. If it's too much, they're getting too much to eat. Is it 8 pounds? Is that way too much? Or is it 4 pounds? And it's, what's going on here? We need to understand to get more nutrition, or let's say, wait, how much are you feeding this baby? The first expected fine motor developmental milestone for an infant begins with fine motor is fingers, right? F, fine, F, fingers. Finger, what do we do with our hands? Fingers. First one. Again, it's that reflex. This is when the mommy puts her finger in to the baby and they grasp it. It's that reflex. They go, oh, look, my baby's giving me a hug. She's holding my hand. Don't ever tell them it's a reflex because they think their baby's giving them a hug, okay? At 8 months old, infants should be expected to perform which fine motor skills? What are we going to do with our fingers at 8 months old? So at 8 months old, they should have a voluntary grasp, right? Palmar grasp, and they should be able to at least smush those puffies or those Cheerios into the mouth, right? Perfect. Good job. The natural physical developmental sequence that most children follow is, and this is your gross motor skills. Physical, what do? Gross motor. Well, the first thing a kid does is lift their head, and by about 3 months. They should roll front to back by 4 or 5 months, back to front by 6 months, and then they should be up crawling, cruising, and then walking or attempting to walk by 1 year old. Which behavior indicates that an infant has developed object permanence? What does that mean, that object's permanence? So even though a toy is not in sight, they still know it's there if they've seen it before. I mean, babies goes looking underneath blankets for it. Infant or toddlers, they still know the toys in the toy box. They still know it's there and they go looking for it. So they actively go searching for it because they know even not in sight, it's still there. In general, an infant should triple their birth weight at what months of age? And these things are important because we're measuring nutrition, right? And then not only with the weight, you're going to be looking at their height, and we're also going to be looking at their fine and gross motor skills, if they're developmentally where they should be. And we know if they're doing triple by 12 months old, we know they're getting their proper nutrition. We put enough gasoline in, and they should be where they should be. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. Again, always, before you do anything for a child, you need to get down below them so they can look down at you, and must do it on their developmental age. Talk to them, play with them on their developmental age, and then they'll do it for you. According to Piaget, toddlers are in the blank developmental stage. Again, it's all about cognition with Piaget. Again, theorists is something that you're going to have to go through and look at. There's 4 or 5 questions on it, and it's called sensorimotor. Very good. Which intervention helps a hospitalized toddler feel a sense of control? Toddlers are ages 1 to 3. And these children like mom and dad there, don't they? They also like their things around them. They don't like to be out of their environment. I think toddlers are the hardest kids to even take on vacation, right? Because they're out of their thing. So, number one, you want them those normal routines, absolutely. And you can't require the parents to stay, but if they can stay, that also will help. But routines, feedings, bedtimes, all the same. And if parents could be there, even better. All children reach developmental milestones at the same age. Yes or no? Absolutely not. They're all different. You have kids walking at 9 months and some at 15 months, right? Immunizations for a 4-month-old infant. Which action should the nurse take to provide traumatic care for the infant? And what did we do for my grandson for his circumcision? Same thing. Good old pacifier with sugar water. Absolutely. And then we can put cool packs on them. We can do some bicycling when they're done. And of course, Tylenol will prevent pain and fever for the first 2 days at least. Which of the following immunizations can be administered to a newborn? Usually at birth, before a child go home, there's one immunization that they do give. And if not, they give it at the first doctor's visit. And it's hepatitis B. The other ones will go over when they should be given, and we'll talk more as we get into that. The normal heart rate for an infant is 140 to 160. Very, very good. Remember, as they get older, the numbers come down. But yes, good job. What is the preferred site to give an injection for an infant? And if you look at that picture, I wouldn't want to be that nurse giving that injection. It's very unsafe. What do you say? As vastus laterus in the thighs, we give them to start with. And they get older, we can give them into the deltoid, and then into the buttocks later on, right? And they can walk. The death of an infant under 1 year old with no known cause is what? And we're going to discuss this more about back to sleep. And it's called SIDS, or sudden infant death syndrome. And we're going to talk about some of the reasons why. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why does she do that? It's respect. Very good. Yes, it is. A child from Mexico is hospitalized for a serious illness, and the father says The child's being punished by God. Why is the daddy saying that? Absolutely what they believe in, okay? And we need to understand those things that the father's saying that, because you're like, what is he saying that? Which term refers to times in an individual life when he or she is more susceptible to positive or negative influences. Remember, there's all those little terms that I showed you on the PowerPoint. And this is called the sensitive period. Yes, it is. What is characteristics of the pre-operational stage of cognitive development? So thinking is concrete. They have to see it to understand it. That's what concrete means, okay? And we'll go into that more next week. So see how we did? According to Kohlberg's moral reasoning, what is the preschooler stage of moral development? Preschoolers. Last question. Preschooler, ages 3 to 6. What do they understand about right and wrong, right? That's what it's all about. And they know that actions are either good or bad. And they know it by what do they get? What's their consequence? Are they getting praised? Are they getting yelled at, right? And that's what kids think about at that point. Number 3, Fluffy. Okay, Fluffy. Number 2, Morgan. Somebody outbeat you in the end. Number 1, Ciara. Good job, Ciara. Number 4, Gabriella and Jessica. Okay, so that is the end of today in the lecture. Remember, you have your first discussion question that is due. The first post is due by Wednesday. If you have enough there that you could do more than that, you may go ahead and finish it all up. Remember, there'll be a quiz, not this coming up a week because you don't have class, but there'll be a double quiz on week 3, okay? And I'll ask you then, do you want to do which one first? Do you want to do week 1 information quiz or week 2 information quiz first? And I'll let you all make those decisions when we get there, okay? Any problems, any questions, please remember, talk to me, all right? Send me a message. I will get back. You'll have my cell phone numbers, and I will be posting this recording. And if you weren't able to open any of the attachments, you let me know, and I'll make sure that you all have them, okay? I hope you had a good class. Thank you so much. Nice meeting you all. Take care.
Bye, thank you.
Thank you. Have a good evening.
You too.